Hi, everyone. My name is Leah Chapman from Magellan. Today, we're sharing a clip from the Bucks County Crisis Training last year presented by Nick Margiotti. Nick discusses the benefits of community stabilization versus higher level of care. Community providers are involved in an individual's care and helping them navigate and understand what the person needs. Let's listen to Nick to discuss this further.
So next slide. So let's talk a little bit. And obviously, this is the crux of where we started this morning, right? Community stabilization versus higher level of care. When it's appropriate and we're able to, I hope we all feel that community stabilization is the preferred answer, right? It's person-centered care, it's meeting people where they are, and it's least restrictive, right? That is what our whole system is built on, those precepts, right? So we obviously want to keep people in their community when we can. There are times they need to go higher level of care, and obviously it's appropriate when we need to. But what's kind of that difference, right? So in community stabilization, you remain connected to your natural supports, your friends, your families, your hobbies, your job, school, whatever those things are, you're able to do. Zooming with your friends, Facebooking with folks, right? You're able to do that. You're able to continue with your outpatient services, whatever stuff you guys are delivering day in, day out. And we had like 9 different jobs in there, but you're able to continue to access those services as we go. You can do your daily routine. You like to exercise, you like to shower, you don't like to shave, but you like to do something else, whatever it may be. What is it that you naturally do? You're able to stay with that. You retain your freedom, right? It's least restricted. What your 302 is, by definition, coercive, right? It's forced. It's taking that away so people are able to do it. And then you're actually able to help engage those coping mechanisms for self-management, which is what we want people ideally to get to. It's great that you can help somebody through a crisis, and hopefully you're feeling more confident with doing that. And we certainly need and want you to do that. But the end goal is so that, Leah herself can start self-managing her crises independently too, and build that strength, right? So all those neat things happen in community levels of care. And when it's safe and we can build a structure to do it, it's wonderful. On the flip side, higher levels of care are necessary at times. They do provide safety. They're frequently locked. A lot of people think different things happen there than kind of what they do. You really kind of get limited access to your supports. You might get 1 hour or 1 visitation daily. In COVID, I'm not even sure if you're getting that anymore. Depends on how different hospitals are working, right? You typically get 5 to 10 minutes of doc or nurse practitioner a day. I know a lot of people think, we'll get you in the hospital, the doctors are there. You're going to have doctors hanging out in your room all day long. They kind of breeze through as they're making rounds real quick, right? So again, these are oversimplifications, but you're not getting hours and hours of psychiatrist time when somebody goes inpatient. It's just not the reality. You get limited connection to outpatient services. Just think of all of your folks. How often are you directly engaged and involved when folks are inpatient for a while? And even if you are, is it more just kind of that figurative pat on the head? Hey, this is what's going on. Are you truly involved in their care? Are you continuing with the things you had already done? Or is the inpatient setting doing what they feel is best in the moment, right? And so we're disconnected. Hospitalizations can be traumatizing, right? It's certainly, it's certainly a limitation of your freedoms. You can see other folks that maybe are more acute, more psychotic, more whatever going on. That may not be the best thing. And you start potentially learning that I can't manage my own symptoms, right? Anytime I'm having a bad day, I gotta be impatient. And you truly are kind of limited what goes on. Now, hopefully there's a couple, at least some type of groups going on there, some skill groups, some art groups, some hobby groups, maybe some talking time. So I'm not saying nothing happens in there, but a lot of times people think you go in and you're getting 8 or 10 hours of programming, and it's high level staff doing that. And that's just not usually the case. So there are times hospitalization is needed. Clearly, nobody's saying it's not. It certainly makes sure that somebody's in a safe place. But a lot of the therapeutic stuff isn't always happening. Nowhere to the degree as effectively as it happens back in the community. And frequently it interrupts whatever you guys were involved with. So we want to make sure that we kind of just understand what happens in these levels of care. Because I know when I first started working into the behavioral health system and interfacing, I just figured the hospitalizations like this panacea, rainbows and unicorns, the whole world changes in there. And it's not always the case. So let's go to our next slide. Kind of this, I talked about most of it. Would have been better if I had read your slide beforehand. But yeah, so we've talked about a lot of these. These aren't the normal place problem solving areas, right? So if we can teach in the home environment, isn't that better? Look how happy they are. They're all high-fiving because they're in a nice home environment. That's a very good slide. They're all vaccinated too, yes, apparently. But we can mobilize the resources and supports and the support networks around folks to help them maintain being into the community stabilization. And you are a big part of that, right? And so it's part of why, if we go back to like slide 3 or whatever, it's why there's such a big push from Bucks County, from Magellan, and frankly, nationally. This isn't just a local initiative to have outpatient community services, however, that phrase applies to you, directly involved in intervening when folks are experiencing a crisis, because you know the person the best, you have the best insights, hopefully you've helped develop that crisis plan, you have a lot of built-in connectivity anyway, and then you're going to be helping them support with the ongoing care after it. And what better way to have that be entirely coordination of care rather than these discrete third parties that need to plug in and out. Again, there's times we need the discrete third parties, but ideally it's a lot more continuity of care if you can be involved through that whole cycle. So let's go next.
Thank you for listening today. If you need further information or assistance, please contact Magellan or your local crisis resource.